Regards from Bayer Oncology. Thank you for joining tonight's discussion on prostate cancer. Today we have Dr. K. Meherlakshmi, ma'am. Ma'am is a HOD, Department of Medical Oncology, Nizam Institute of Medical Sciences, Hyderabad. Ma'am, over to you.
Thank you, Sandeep, and I thank the Bayer team for this opportunity. Today, we will be discussing about the recent developments in the field of metastatic hormone-sensitive prostate cancer. As the longevity of patients, longevity of our population is increasing, we are seeing more and more prostate cancer cases. And the treatment options have also emerged. There are various developments in the management of prostate cancer in the recent years. So we'll be discussing a few salient points in the treatment. The first talk is by Dr. Venkateshwar Rao. He is the senior consultant medical oncologist from Omega Hospital, Visakhapatnam. Over to Dr. Venkateshwar Rao.
Good evening, ma'am. Thank you for giving me this opportunity, and thank you, Bayer team, as well. Is my screen visible?
Yes, sir. Visible and you're audible, sir. Please
Yeah.
go ahead.
So today we'll be discussing on the ARANOTE trial. To start with, if you see the treatment evolution in patients with prostate cancer, especially the hormone-sensitive prostate cancer, way back in 2014, we had this Charter trial followed by the Stampede trial. We had multiple arms in them. And then prior to this, we only had ADT in the management of metastatic HSPC patients. And then we started combining ADT with either docetaxel or abiraterone. And then we had the evolution of these androgen receptor pathway inhibitors. We had multiple drugs here, enzalutamide, apalutamide, and then the recent darolutamide as well. So all these drugs, when combined with ADT, have shown a significant improvement in survival and other secondary outcomes like delay in progression to CRPC as well. Despite treatment with ARPI with ADT or docetaxel with ADT, a large proportion of them still progress to CRPC within a short period of time in less than 3 years. And then we had two new trials, the PEACE-1 trial and the ARASENS trial. The PEACE-1, which had a slightly complex trial design, which used abiraterone with ADT in combination with docetaxel plus or minus radiation therapy in upfront metastatic HSPC patients, and ARASENS with a simple trial design. It had combined darolutamide with ADT plus docetaxel, and both of them proved to have shown significant improvement in overall survival, especially in the high-risk patients. And the triplets are not for everyone. So we all know that prostate cancer patients are elderly patients, difficult to manage because of multiple drugs, that is polypharmacy, and also the tolerability of triplets is slightly challenging in that age group. So usually in unfit patients, we prefer with doublet agents. However, the outcomes with doublets are also good, and here we have data with darolutamide as well. Previously, we had only data for other ARPIs, but now with ARANOTE, we have darolutamide in the doublet space as well. So we look into how darolutamide has fared in this set of patients. So as I already mentioned, the ARASENS trial, triplet had shown significant efficacy in high-risk patients, and we look at ARANOTE trial now. If you look at the study design, nearly 665 patients were included in this trial. There was a 2:1 randomization among them. Darolutamide was given at a dose of 600 mg/d, and the main primary endpoint was PFS. Secondary endpoints were overall survival. There were many secondary endpoints like time to initiation of subsequent antineoplastic therapy, time to CRPC or time to PSA progression, and even rates of undetectable PSA, that is less than 0.2 nanogram per milliliter, and also time to pain progression as well. And there was also an open label phase of this trial where darolutamide was allowed to cross over. Coming to the baseline characteristics are very well matched between both the groups. Nearly 32% of the patients in this trial were Asian patients, and nearly 70% of them were upfront metastatic patients, and nearly again 70% of them had high-risk disease at presentation. Only 10% near to 10% of patients had visceral metastasis, and another 20% of patients had received prior local therapy. So if you look at the patient distribution of various other trials, majority of them have included patients in the North American region and the European region. But specifically, the Serano trial had included Asian patients and Chinese patients as well. If you look at the Asia Pacific region, nearly 40% of the patients are from Asia Pacific region, including patients from India as well. So this data is very much applicable to Indian patients as well. So coming to outcomes, darolutamide plus ADT had significantly reduced the risk of radiological progression of death, which was the primary endpoint of this trial. So the median radiological PFS was not reached with the darolutamide arm, whereas it was 25 months in the placebo group. The hazard ratio was 0.54, so there was a nearly 46% improvement in radiological PFS with use of darolutamide combination therapy. If we look at the various subgroups here, almost all the subgroups had shown benefit with use of darolutamide, and the benefit was even more prominent in the patients who had low volume disease, where the HR was only 0.3. Similarly, patients who did receive previous local therapy, they had a even better response when compared to other groups. But overall, almost all the groups, irrespective of baseline PSA, irrespective of their performance status, irrespective of the volume of disease, everyone had fared well with use of darolutamide combination. Coming to secondary outcomes, OS is still immature, whereas other secondary outcomes like time to CRPC or time to PSA progression, time to initiation of subsequent systemic therapy, or time to pain progression, all were significantly improved with use of darolutamide when compared to placebo plus ADT. Coming to each secondary endpoint, here you can see the KM curves for time to metastatic CRPC. It was not reached in the darolutamide group, whereas it was 13.8 months in the placebo group with a hazard ratio of 0.4. Similarly, time to pain progression, the median time to pain progression was not reached versus 29.9 months in the placebo group with a hazard ratio of 0.7. If you look at depth of responses, patients who had a PSA of less than 0.2 at any time of treatment was nearly 62.6% in the darolutamide group, whereas it was only 18.5% in the placebo group. And time to PSA progression was also not reached. Median time was not reached in the darolutamide group, whereas in the placebo group, it was only 16.8 months. So 63% of patients in the doublet group had attained a PSA of less than 0.2. This represented a 69% improvement in time to PSA progression in darolutamide arm. So here you can see the depth of PSA response in high volume and low volume diseases. In low volume disease, PSA less than 0.2% was seen in approximately 50% of the patients, whereas in low volume disease, it reached almost 80%. So the depth of responses were even better in the lower volume disease when compared to high volume disease. If you look at how many patients had received subsequent line of therapy, we all know, I had already mentioned that crossover was permitted when the trial was open labeled. In the darolutamide group, around 32% of patients had received subsequent therapy, whereas in the placebo group, nearly 42% of them had received it. And most of the second line treatments which were taken were docetaxel, abiraterone, or enzalutamide. Coming to adverse events, incidence of treatment-related adverse events were similar between both the experimental arm and the placebo group. Any adverse event was reported in nearly 90% of patients, whereas grade 3 or 4 adverse events were seen in 1/3 of them. Median treatment duration was 24.2 months in the darolutamide arm versus 17.3 months in the placebo arm. If you look at drug discontinuation rates, it was lesser in the darolutamide arm when compared to placebo. It was 9% in the placebo group, whereas only 6.1% in the experimental arm. So the safety profile of darolutamide in ARANOTE was independent of PSA response and consistent with the favorable tolerability first seen with the other trials. So we had ARAMIS and ARASENS trial results previously, and no new safety signals were reported in this trial as well. So the most common adverse events which were seen in more than 5% of patients were anemia, arthralgia, UTI, back pain, derailments in LFTs, hypotension, body pain, or increased weight. And if you look at fatigue here, fatigue was better in the darolutamide group when compared to the placebo group. So the adverse events which we commonly seen with other ARPs like hypertension, vasodilation, diabetes, cardiac arrhythmias, and other CNS side effects all were comparable with that of placebo. So there were no new safety signals. Most of the side effects were very well tolerated. And when compared to other drugs, darolutamide is very much safe and the rates of side effects are even less. Coming to quality of life, darolutamide extended the median time to deterioration of FACT-P total score by 5.1 months. So the FACT-P score was measured and time to deterioration was nearly 11.5 months in the placebo group, whereas in darolutamide group it was 16.6 months. So darolutamide is first and only androgen receptor inhibitor to demonstrate a clinically meaningful delay in pain progression as well as overall well-being of the patient. Coming to the various factors which were seen in the FACT-P score, this included physical well-being, social well-being, emotional well-being, and functional well-being as well. And the various symptoms related to prostate cancer, like the urinary symptoms and bowel symptoms, were also included. And most of them favored use of darolutamide. So all the symptoms had significantly come down with use of darolutamide when compared to placebo. So to conclude, darolutamide plus ADT significantly improved the radiological PFS in patients with metastatic HSPC. And darolutamide showed a benefit across all secondary endpoints. It was associated with deep PSA responses. Regardless of baseline PSA, responses were better in the low-risk group. The deeper responses were seen in the low-risk group. And darolutamide is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, including social, family, functional well-being, and even urinary and bowel symptoms. The safety profile, there were no new safety signals. So darolutamide plus ADT without docetaxel should become an additional standard of care in patients whom we do not consider for a triplet therapy. So ideally for high-risk patients, if tolerable, go for triplets. For low-risk patients, DARA-based doublet is also a very good option. Thank you. So thank you, Mayor Madam, and thank you, Bayat.
Thank you, Dr. Venkateshwara. That was a very nice presentation. And we all of us have been using darolutamide, and this data, it will help us. We have no evidence to it. And now the second talk is by Dr. Nageshwar Reddy. He's the Chief Consultant Medical Oncologist from Swikar, Tirupati. Over to Dr. Nageshwar Reddy.
Thank you, madam. I'm sharing my slides.
Sir, is it possible to open your camera, sir?
Yeah, I have opened from another mobile because some problem with my laptop.
Yeah, fine. It's okay.
Is that okay?
Yeah, okay.
Yeah. Are the slides visible?
Yeah, slides are visible, sir. Can you make it a presentation mode, sir? And you're also visible, sir.
Yeah. Thank you. So, good evening, all.
Yes, sir.
Thank you,
please go
madam.
ahead.
Thank you, Bayer, for giving this opportunity. And this is a sponsored talk, and the slides are provided by Bayer Pharmaceuticals. And this is the typical course of a prostate cancer patient. Usually in countries or regions where there is programmatic screening procedures, most of the patients are diagnosed in localized prostate cancer. Whereas in those countries like India, where there is no programmatic screening procedures for prostate cancer or other cancers, majority present in late stages, that is metastatic disease. And when a patient presents with localized prostate cancer, they usually takes treatment for localized prostate cancer, and then they recur. And then they recur radiologically also, which we call as them as metastatic cancer recurrent. If the patient has not received any hormone therapy and hormone naive, then we call them as hormone sensitive prostate cancer. If the patient progresses on hormone therapy, then we call them as castration resistant prostate cancer. One important point which is notable here is if somebody says castration resistant prostate cancer, that is very heterogeneous disease. And most importantly, the factor which needs to be considered is what treatment they have received. For example, in earlier days when we were in NIMS and giving treatment, most of the patients received only ADT, and then subsequently they received other forms of treatment like abiraterone or docetaxel. So in those patients, CRPC will have a very good survival because they are not exposed to abiraterone or docetaxel. But in the current scenario, where the patients, most of the patients are exposed to upfront ADT plus abiraterone or darolutamide or docetaxel, the survival and the treatment options in these patients is very less. So the main focus of current day's topic is metastatic hormone sensitive prostate cancer. And when we see patients who are really fit and affordable, it's important to intensify the treatment in the first setting itself. That is, if a patient presents, then it is better to give triplet therapy if at all the patient is affordable. And this is the survival graph from the STAMPEDE trial. The orange line shows the survival of the patients with metastatic prostate cancer who received ADT alone, whereas the lower graph, which is green in color, represents the failure-free survival. Here, FFS is a composite endpoint, which is defined by one of the following, like PSA progression or death or radiographic progression. So there is a wide gap between the two survival curves, meaning those who fail also they do better. Meaning in those days where ADT was the only treatment in the first line therapy, the subsequent therapies added to the survival. And the same STAMPEDE trial has shown that addition of radiation therapy to those patients with low volume disease, meaning patients with less than 4 metastasis, addition of radiation therapy improved survival and failure-free survival. So in patients with low volume disease, it is better to add local radiation therapy to the prostate. That improves the survivals. And this is the timelines over which different trials have been presented the data, which led to the improved survivals. And the notable articles or notable trials include CHARTED, STAMPEDE, LATITUDE, ARCHES, TITAN, ENZAMET, and PEACE-1 trials. And of course, the ARASENS trials, which we are going to discuss today. So CHARTED trial, this is the trial which has defined the volume disease, disease based on the volume. If it is more than or equal to 4 bone metastasis with at least 1 metastasis outside the axial skeleton, then they fall under high volume disease. And those patients with less than or equal to 4 bone metastasis, these are low volume disease. So CHARTED trial is a randomized phase 3 trial wherein patients were divided randomized into 2 groups, ADT plus placebo versus ADT plus docetaxel. So in the docetaxel arm, the overall survival has shown superior results. But when they analyzed based on the volume status or high volume or low volume, it is the high volume patients which has shown superior benefit. 51 months versus 34 months with hazard ratio of 6.63. That is around 37% decrease in the risk of death in patients with high volume disease. Whereas in low volume patients, there is no benefit is not statistically significant. So docetaxel, if at all, is considered in fit patients, it is better to consider only in high volume disease because low volume disease did not show benefit. And the Latitude trial, this is also a phase 2 trial wherein patients with high risk metastatic hormone sensitive prostate cancer were divided into two arms, ADT plus abiraterone acetate and ADT plus placebo. Here the risk is defined based on three factors: grade group 8, grade group 4 or more than 4, and presence or absence of visceral metastasis, and presence of 3 bone metastasis. Presence of any 2 risk factors were included as high risk, and those patients only with high risk were included in the Latitude trial. Addition of abiraterone to the ADT arm has improved survivals as shown in the graph. So the graphs are well separated and they did not meet even with the time. The survivals are, as mentioned, it's around 53 months in the doublet arm, whereas it is only 36 months in the ADT alone arm. And one important point to note is the PSA time to PSA progression is around 7 months in the ADT arm, whereas it is 33 months in the ADT plus abiraterone arm. And there are certain side effects which are not so common but well manageable, which includes hypertension, hepatotoxicity in the form of transaminitis, hyperkalemia, and fluid retention. If you look at these adverse effects, most of these adverse effects are because of the fluid retention, which occurs because of the inhibition of hormone synthesis with the abiraterone. And that is the reason why we usually give prednisolone. So prednisolone, if given along with abiraterone, that decreases the chance of adverse effects which are associated with the mineralocorticoid excess. And other anti-androgen is apalutamide, which was tested in Triton trial. Again, this is a phase 3 randomized trial wherein patients are randomized between apalutamide plus ADT versus placebo plus ADT. And it also has shown improved survivals, both PFS and overall survivals. When data was interpreted based on the volume status of the disease, both the groups, high volume disease and low volume disease, were also benefited. And other anti-androgen, enzalutamide, was also tested in the Enzamet trial, and it has also shown benefit mainly in the low volume disease. And one problem associated with enzalutamide trial is it crosses the blood-brain barrier and can result in seizures. Though the incidence of seizures is less, it's around less than 2%. So, and one advantage is those patients with brain metastasis, which is not so common in prostate cancer, can be treated with this combination. And till now we have discussed ADT plus this second agent, either docetaxel or abiraterone or apalutamide or enzalutamide. Let's see the triplet regimens. We have 2 triplet regimens from the PEACE-1 trial and the other from the ARSENS trial. PEACE-1 trial is again a 2x2 factorial design, wherein the patients are randomized between standard of care plus radiotherapy, abiraterone plus prednisolone, and then standard of care plus abiraterone plus radiotherapy. Here, standard of care means ADT plus docetaxel. So it was amended in between. So standard of care included ADT plus docetaxel. In this trial, those patients with high volume disease has shown superior survivals with the triplet regimen. But those patients with low volume disease did not show superiority with the triplet regimen. In patients with low volume disease, giving doublet is also fine. That is standard of care, this thing. The ARASENS trial. This is a global randomized phase 3 trial wherein the patients were randomized between standard of care, that is placebo plus docetaxel and ADT, to the experimental arm docetaxel, darolutamide plus ADT. And the patients included were all patients with metastatic hormone-sensitive prostate cancer who were having ECOG PS of more than or equal to 1, and those who are candidates for both ADT and docetaxel. And the stratification factors were extent of the disease and alkaline phosphatase levels. The endpoints were overall survival, and the secondary endpoints being time to castration resistant, time to pain progression, or symptomatic progression, or time to first symptom, or time to next antineoplastic therapy. And around 87% of the patients in this trial received all 6 cycles of docetaxel. And adverse events were also similar between the both arms. And this is the final overall survival. And here we can see there is well separation and very good gap between the darolutamide and the standard arm, with hazard ratio of 0.68, that is 32% reduction in the risk of death with the triplet arm, and 4-year overall survival is around 50% with the doublet arm, whereas it is 63% in the darolutamide arm. And this benefit is consistent around the both group of patients, low risk and high risk patient. This is in contrast to the PEACE-1 trial, where only wherein only high volume disease patients were benefited with the triplet arm. And key secondary endpoints were also benefited, and time to CRPC, time to subsequent antineoplastic therapy were improved in a good way, whereas other secondary endpoints like time to pain progression, time to first symptomatic skeletal event were improved statistically, but clinically it was only milder improvement. And in this trial they also looked at those patients with PSA response. PSA response, undetectable PSA levels were defined as PSA levels of less than 0.2, and the depth of response was better in the triplet arm at all the time points: 24 weeks, 34 weeks, 52 weeks, and cumulative any time. And if you take only those patients with undetectable PSA, the time to PSA progression was better in the darolutamide arm, and it was well separated in those compared to the patients with detectable PSA. Coming to the overall survival, here also those patients with undetectable PSA levels, they did well compared to those patients with detectable PSA levels. And similarly, PSA responses, if you split between high volume and low volume, here also patients with undetectable PSA did better with respect to time to PSA progression and also overall survival. Even in low volume disease, those patients with undetectable PSA did well with respect to PSA progression and overall survival. So whenever we are considering the treatment for metastatic hormone-sensitive prostate cancer, the first thing we need to consider is whether the patient is fit for docetaxel or not. If the patient is fit for docetaxel, we can use abiraterone. I mean, there are two options, either the PEACE-1 protocol or the ARASENS protocol. But what I have found is those patients with diabetes and not well controlled the sugar levels, abiraterone with prednisolone has resulted in poor glycemic control. So in those patients with uncontrolled sugars, or in those patients with cardiovascular diseases, darolutamide plus ADT plus docetaxel does very well. So, and we also need to consider the extent of the disease, age expectancy. And one thing we need to remember is in those patients who progress after ERPA, the chance of response to dostaxel is less, and patient needs to be informed of all the options. I once again thank you for giving this opportunity. Thank you, Meher Madam. Thank you, Bayer. Thank you all.
That's a very nice presentation, Dr. Nageshwar Reddy, and it was nice hearing to your experiences and your take on the use of triplet with darolutamide. So, can you stop sharing your screen?
Sure, Bayer.
I'll share a small case from my
Yes,
side.
ma'am.
Let's say, shop. How do I share?
Yeah, I stopped, madam.
Yes, I'll start. Just a moment. I hope my screen is visible.
Yeah, visible, madam. Visible and audible.
Thank you. This is the case of a 83-year-old man. He presented with body pains of 3 months duration in December 2022. He was diagnosed with carcinoma of prostate in 2006 when he presented with hematuria. In 2006, he underwent radical prostatectomy. At that time, HPE was adenocarcinoma of prostate with Gleason's of 6. In 2020, when he presented body pains, this was the bone scan that was showing PSMA PET CT shows PSMA avid focus in the prostate bed adjacent to the surgical clips, recurrence or residual disease. This is actually a recurrence in 2020. So he presented local recurrence in the bed of prostate in 2020, for which he underwent radical RT, and again he defaulted for follow-up in view of COVID. And 2022, he was investigated again for body pains that showed a rise in PSA values. November 2022, it was 7.87. December 2022 was 10.7. And the one more value is 13.5. And then PSMA PET CT was done for this patient again. So this is the PSMA PET CT in 2023, and we showed a lesion in the prostate bed that shows persistent PSMA uptake and sclerotic lesions with increased PSMA uptake in the pelvic girdle bones, which is a new finding due to suggest to a disease progression. And he was discussed the various treatment options in view of elderly age. Chemotherapy was not planned, and he was discussed the side effects of steroids when given with Abiraterone. As Dr. Nageshwar Reddy was saying, yes, we see a poor glycemic control when steroids are used, and they must be having they can have other side effects with steroids, including one patient who was on steroids for a long time had myopathies. And of course, there is a risk of fall when we use enzalutamide for such an elderly person. So he was started on darolutamide 600 mg BID along with monthly denosumab 120 mg and 6 monthly leuprolides 45 mg. He became symptomatically better in a month. 45 days after starting darolutamide, PSA was 5.6 nanogram per ml. PSA done in May the same as 2.69. He was asymptomatic and was continuing therapy. Thank you. This is a small case from my side. How do I stop? Yes, sir. Doctor, I thank both the doctors for the excellent job. Both Nageshwar Reddy and Nageshwar Reddy and Venkateshwar Rao. Over to Sandeep.
Ma'am. Hello.
Yes,
Am I
yes.
audible, ma'am? Yeah.
Yes.
Thank you, ma'am. I think Dr. Venkateshwar sir left because of traveling. I think sir is in travel. So, ma'am, would you like to ask any questions a discussion with Nageshwar Reddy?
Yes, already presented all the points and regarding doublet and triplet. I don't think there is more
Yes.
to discuss.
Yeah. Okay, ma'am. Okay, ma'am, let me check any questions from the chat box. If not, then we can continue the session. Yeah, I don't see any questions in the chat box, ma'am. So I think, thank you, ma'am. Thank you so much for taking your time. So I thanks to Dr. Meher, ma'am, for your excellent case presentation, and I thank to Dr. Venkateshwar Rao, sir, and Dr. Nageshwar Reddy, sir, discussing about RSNs and RNO data. So with this, thank you, ma'am.
Thank you. Thank you.
Thank you, sir. Thank you.
Technical team. Hello.